Recording in progress.
Also, good evening, people in Thailand. So welcome back to the IOC lecture series. So this is part of the collaboration with Indiana University that we are broadcasting the lectures that we give to the trainee at Indiana to the people in Thailand and also in the Southeast Asian country. So this is the episode 3 of the lectures that we are going to talk about the imaging of epilepsy. So last month that we talking about some genetic or like a cortical malformation that related to mTOR and tubulinopathy that more focus on the epilepsy in children. This week, we are going to focus more maybe like a teenage and also young adult. So this is my great pleasure to have one of the best speaker that I have known for several years, Dr. Kamer. He was a fellowship program director before me and also the residency program director. He is really engaging in education. He has like a very unique technique to teach people on how to remember things or like point something out to the trainee. And today I have Dr. Namphon Tavi Asani from Thailand as a co-moderator to help me monitor the chat box in the Facebook and YouTube. So welcome, Aaron. So this is your show.
All right, thank you, Tanya. Let me share. Okay, so one of the things that that I do regularly is participate as the radiologist in our epilepsy conferences, in our multidisciplinary conferences. And early on, when I started doing that several years ago, I found that many of the findable abnormalities that patients have for as a cause for epilepsy that do show up on MRI were actually not being detected by a lot of our radiologists, and a lot of the reason for that is that these abnormalities tend to be very subtle. They tend to be difficult to find, and it's only through a very targeted search that you can find these abnormalities. And over the years, as we have paid closer and closer attention to how to find these abnormalities, how to detect them, and how to serve our neurologists and neurosurgeons in being able to treat these patients, we've gotten better and better at it. And I've accumulated some cases that I think would be helpful as well that we can talk about a little later in the lecture. So that's a little background. So my main objective for this conference is for our participants to be able to understand some of the, to be refreshed on some of the pathophysiology of epilepsy and to understand where the seizures are coming from in our patients that we're evaluating for them, and then maybe how to tailor their search a little bit better to look for these causes of epilepsy in our older children, young adult, middle-aged adult patients. All right, no disclosures. So as far as significance of epilepsy, here are several factoids about the disease. One thing that amused me about this image that I came across online is that we've got such cheerful characters that are introducing something as tragic as sudden unexplained death in epilepsy, which can definitely happen and is one of the biggest concerns for our neurologists as they're trying to take care of patients with epilepsy. We don't want these to be, high mortality patients. All right, so let's talk about some of our goals in imaging in epilepsy. First of all, what is the basic pathophysiology of seizures? I usually like to ask some of our participants to help me out on this. Do any of our residents want to take a stab at this? Why are our patients having seizures? When I leave it so wide open, we may not get many participants here.
Infection.
All right, absolutely. So we can have infection, either chronic or acute. Yep, many causes. So let me actually back up even a step from that and start talking about, what's going on behind the scenes as a common denominator in all of our epilepsy patients. So seizures are coming from neurons. They're generally coming from neurons that have some degree of malfunction to them and they're misfiring. Okay. There are certainly genetic factors to this. We see many patients who have epilepsy from birth, many of which that we never find an actual structural abnormality with. And in the setting of DNA, the DNA contributors to this, there's also a significant component of nature. So it's a not a nurture in nature, but rather a genetics and nature. Something. So our environment can actually significantly impact how likely we are to get epilepsy. Patients who tend to have epilepsy have dysfunction with sodium-potassium ion channels, as well as some of the ligand-gated channels. So nearly all genetic causes of epilepsy are related to membrane transport of ions. So it seems to be a propensity of the neurons to basically misfire, to trigger as a result of some of these genetic defects in either ion or ligand-gated channels within the cell membranes. Studies were being done on the genetics of epilepsy as far back as the early 1950s. Here is a study that was performed in the setting of monozygotic versus dizygotic twins. And you can see that generalized epilepsy in this case, in monozygotic twins, identical twins, had a much higher concordance rate than in dizygous twins. So there is a very significant, tailored to the DNA genetic contributor to epilepsy that should definitely not be overlooked. There are a lot of other causes of epilepsy. This is, illustrating the fact that certainly patients who are young, it's very, very common to get febrile seizures. In fact, 3% of children under 5 years old have febrile seizures. That certainly does not mean that they will go on to have epilepsy, but a significant portion of our patients who have mesial temporal sclerosis, the primary abnormality that many radiologists look for, have had febrile seizures as a child. Trauma is a significant cause of epilepsy as well. We have, if a patient has had damage to their brain parenchyma, especially the cortical components of the brain parenchyma superficially, which is what happens so often in contusions, they can have a propensity for epilepsy throughout their life. Alcohol is a significant contributor, especially in patients who are genetically predisposed to having epilepsy. So when patients have a significant history of alcohol, I think it's reasonable to take that into account when accounting for their seizures. All right, so now we're going to move into a little bit of how seizures are assessed. And this is something that I'm going to talk about from a multidisciplinary approach. I don't have strong expertise in the different areas of assessment, but I think it's reasonable and helpful for a radiologist to know how the workup tends to occur in these patients. So the first and foremost way that our neurologists are working up epilepsy, and it is usually neurology that takes control of these patients and guides them through the process of both assessing and then treating epilepsy. They are breaking it down into several categories. Generalized seizures, some of which, ranging from those that affect the patient's whole body, all the way to those that are a little bit more benign and don't have as strong of an impact on the patient's daily life. Many patients have partial seizures as well, affecting only motor or sensory of a specific body part, and some may even have some psychological seizures. So this is the basic breakdown of how neurologists tend to categorize these. And you can see the very strong symptomatic focus of the categorization system that they tend to use, which clues us into the fact that these are generally managed by neurology. So after our patients have been evaluated by neurology to figure out where the seizures may be coming from based on clinical symptomatology, they often have a neuropsychiatric evaluation. One of the reasons for a neuropsychiatric evaluation is to localize where the seizures may be coming from. If a patient has, for example, a significant language deficit, say their intelligence when it comes to language, as assessed by a neuropsychiatrist, is lower than their otherwise average intelligence, or lower than the majority of their other categories, then we start to wonder if the seizures are coming from the left side of the brain or wherever the patient's language centers happen to be. The same is true for a number of other categories. If there is a significant score deficit in one category of the patient's intelligence, we start to think about that area as being damaged or chronically damaged in the setting of epilepsy. So that's one reason for the neuropsychiatric evaluation. Another reason is to test the patient's memory and language centers, to test how amenable they might be to a future procedure that might have to remove portions of their brain that might be affected by those. All right, the third major way that our multidisciplinary conference evaluates patients with epilepsy is through EEG. This is usually performed by a neurologist who has special training in EEG. Many of you remember at least a little bit about EEG from your medical training. In reading these, our neurologists are looking at these are all of the leads, all of the tracers that you see are measuring activity between two leads. And usually they're labeled in the approximate location that these electrical signals may be coming from. So if it says F, it's probably frontal. If it says T, it's probably temporal. And if it has an odd number, it is on the left. And if it has an even number after it, it's probably on the right. And they're using the different waveforms to try to figure out whether there is a seizure either actively happening because they've monitored the patient under video EEG, or if it's a more dormant region of the brain giving off some abnormal tracings because it's potentially epileptogenic and currently interictal. All right, now our favorite part, obviously, is the imaging of epilepsy. So we certainly do MRI, and as we get higher and higher field strengths, we can get a better and better look at our patients' brains under MRI. This is a 1.5 Tesla. I've found that our neurologists are pretty adamant and strongly interested in getting 3 Tesla MRI for the majority of our epilepsy patients. In fact, when we have a patient being scanned for seizure, or we're looking back at some old historical study that the patient has had, one of the first questions that I get asked commonly by our neurologists is whether this was a 3T. And here's, like I said, on the left here, I have a 1.5T, and then here's an example of a 3 Tesla magnet. I don't find that the differences are as dramatic as this example usually, but you can see why our neurologists, especially if they're seeing examples like this in the literature, are very, very interested in getting 3T. This is a clear disorganized cortical dysplasia case, and there's a nodule of gray matter heterotopia here. This disorganized looking temporal lobe is almost certainly the cause of this patient's seizures, given the degree of abnormality in it, and it just doesn't show up nearly as well on the 1.5 Tesla magnet. So please know that our neurologists are often very interested in a full assessment with 3T. Sometimes we will do PET scanning for our patients. Usually with a PET, we're looking for areas of hypometabolism, indicating a zone of our epileptogenic zone as being interictal. We don't tend to do PET trying to capture the seizure. We're trying to get it in the interictal period. The abnormalities that we see, I've found PET not to be super high yield in my practice, but we are also evaluating a lot of patients who are already MR negative. So oftentimes PETs are done in collaboration with the neuroradiologist, and there's a discussion that happens about findings that are visible on the MRI and how that compares to the metabolism that's imaged on the PET. All right, so MEG is something that's done at a lot of imaging centers, and it's basically a way to use magnetic fields in order to try to perform something akin to an EEG, but with deeper brain components, trying to get a little bit more of a three-dimensional look at where abnormal electrical activity is happening in the brain. One of the disadvantages of EEG is that we're only looking at the surface, and we're trying to extrapolate where deeply in the brain the abnormalities might occur, whereas MEG gives us a little bit more of an explicit look at what's happening deeper in the brain. The yield on MEG is intermediate. It can be helpful for a lot of patients, but it's another modality that just needs to be taken with a grain of salt and taken in light of all of the other abnormalities that we're noticing for the patient. If you've never seen an MEG in action, this is what the machine can look like. So the patient is often given different instructions of things to do while they're sitting in the machine, and it's encircling their head. Functional MRI can certainly be used for epilepsy. Resting state fMRI is something that can show us areas that are either not well connected with the rest of the brain and may therefore be a little bit dysplastic. It can show us areas of a little bit atypical electrical activity that's happening in the brain, or activation that's happening in the brain. The setting that I see fMRI used for most frequently is in assessing patients prior to their getting a surgery or another procedure. And the main reason for using fMRI in that setting is to determine, where their language centers are, where their motor centers are, especially in the setting of tumor or another lesion that the surgeons may be going in and going after that could be close to high real estate areas of the brain. So this example here I have obviously showing some language activation in Broca's area and a little bit in Wernicke area that are on the unexpected side of the brain, the less typical, less common side of the brain on the right. A patient like this who has epilepsy coming from the left temporal lobe would be much safer to ultimately do a procedure, do a temporal lobectomy, put a stimulator device in place on the left, because their language centers should be relatively spared in that context. And one of the other things that can be done is some complex morphometric analysis. This is coming more and more in vogue, where computer processing is used in order to assess where different characteristics are happening. For most imaging centers, this is still just in the research realm. It's not super widely used at this point, but there are a lot of interesting tools that can be used to basically either look at the brain in a very unfolded way that can draw our eyes to areas of abnormality, or to do a three-dimensional model where certain characteristics are accentuated. So for example, this computer program is showing gray-white blurring and how strongly it's detecting that in this region in the temporal lobe. Now the gray matter thickness doesn't appear to be tremendously abnormal. The cortical shape, like the gyral shape itself, is abnormal in this area. Doesn't seem to be much abnormal curvature, abnormal sulcal depth. But then asymmetry also shows up as pretty significant. So you can see, your eye is definitely drawn to this area of yellow abnormality on this study. And then going back and looking at the anatomic MRI images, it's a little bit easier to see the abnormality that's down here in the left temporal lobe posteriorly. So we can see that cortical thickening. We can see the blurring of the gray-white in that region of cortical dysplasia. So I talked earlier about 1.5 versus 3. 7 Tesla MRI is something that gives us incredible imaging, but is not widely available except in many academic centers or research centers, and even in those settings is not typically used for clinical assessment of patients with seizures. Obviously, as these things go, we'll see more and more of these likely in the clinical setting to assess seizures. And I'm looking forward to that because I think it'll be a whole lot easier to detect things. As you can see, this is the 3 Tesla magnet. Here's the 7T. It's a good example of an abnormality that's much more clearly visible on the 7 Tesla. One thing that we're also doing a little bit more frequently at IU for our evaluation of epilepsy is using PET-MR. PET-CT obviously is the more common modality, but finding an abnormality on PET-MR makes it a little bit easier to localize that abnormality to the area of the brain, especially when they're scanned concurrently. So here are some examples of good PET-MR using a few different different types of radio tracers and being able to localize those abnormalities even more clearly. Laboratory analysis is one of our kind of late stage evaluation tools for epilepsy if we have not been able to find other things, or if there are specific imaging findings that are suggestive of something like an autoimmune encephalitis. There are a number of labs that can be run to try to figure out if there are autoantibodies to the brain parenchyma that could explain the patient's epilepsy. This is usually done more in the setting of a patient who is demonstrating pretty classic clinical presentation, such as a little bit later onset, having brain abnormalities of atrophy in specific regions, or some abnormal enhancement in certain regions of the brain, to be able to get these autoantibodies tested for. And there are a lot of them. We can do invasive monitoring. This is a fascinating tool to be able to use. This is something that's performed by neurosurgery, obviously. The patient has a craniotomy performed, and then the neurosurgeons use targeted monitoring of the patient in order to place either surface electrodes, which is what this is, or they can also place strips of electrodes that will go underneath the temporal lobe or under the frontal lobe. And they can also place what they call depth electrodes, where they're putting EEG leads deep within the brain, often in the regions of the hippocampus or other potential suspicious areas. They will place these leads and then have the patient undergo in-hospital monitoring. making sure that the patient is at their in a situation that they are most likely to have seizures, because this is an actual ictal monitoring situation. We want to see the patient having seizures and record those seizures as best we can. The reason for this being done is usually we're having a difficult time localizing where the seizures are coming from, and this invasive monitoring gets us one step closer to the part of the brain that the seizures may be coming from anatomically. So if you see something like this on radiographs or on a CT scan, that is what you're looking at. You can see the grid electrodes over the surface of the brain on the left here, and then you can see what appear to be depth electrodes going inward. I assume that this is them right here on the lateral view. You can see those going deeply toward the temporal lobe, probably monitoring areas of the amygdala and or hippocampus. All right, so we talked a lot about how seizures are assessed in a multidisciplinary approach. Now we're going to move into how they are actually managed. First and foremost, because like I said earlier, these patients are managed by neurology. We tend to see patients managed first and foremost with medications. There are a very large number of medications that patients can be managed with for seizures. Unfortunately, a lot of our patients are actually refractory to those medications. So you can see here that not quite the majority, but a large number of patients tend to be seizure-free with their first medication. A smaller percentage are seizure-free with 2 medications or the second medication, and then a much smaller percent with a third medication or multiple medications. But a very large percentage of our patients are actually resistant to any medications, greater than a third of our patients. So this is actually a pretty significant number of our patients that are unable to function very well in the ways that they'd like to in society. These are patients that are not allowed to drive, they're not allowed to operate heavy machinery, and a lot of those things are very, very limiting to them. So in addition to medication, one of the next least invasive things that we can do for our patients is to implant a vagal nerve stimulator. So our surgeons will place a device similar to a pacemaker or another cardiac device in their upper chest, and they'll have leads that go up to the region of the vagal nerve in order to stimulate the patient, stimulate the vagal nerve that does tend to do a decent job suppressing seizures. This is one example of what that device may look like, and you can see the lead instead of leads going intravascularly and into the heart, we're seeing leads that actually seem to proceed up the chest and up into the neck, coil a little bit, and then you can see the little electrodes that wrap around the region of the vagal nerve. Here's a little bit closer view of that. Again, you can see these curved structures here are portions of the vagal nerve stimulator, the lead that is stimulating the vagal nerve in the region where it courses. On a CT angiogram, here's a sagittal MIP image. We can see that vagal nerve stimulator pretty well here. And you can see that the leads are in the region of the carotid artery. That's where you'll expect to see it, because that's where the vagus nerve runs. So don't be confused when you see one of these patients or one of these devices, especially in patients with epilepsy. All right. So vagal nerve stimulators actually do make assessment a little bit more difficult, because it's a little bit complicated to get an MRI. We want to make sure that the patient is safe while receiving their MRI in the setting of an electronic device. Additionally, we see a pretty significant amount of artifact in a lot of our 3D IRSPGR sequences with a vagal nerve stimulator. In fact, it's to the point that if I see this artifact, this linear artifact going across the brain like this, I can be fairly confident that the patient does have a vagal nerve stimulator or other electric device that does have these periodic stimulatory effects. So another type of stimulator that has been coming into vogue is an actually intracranially implanted device that stimulates deeper within the brain. So this is an example of a neuropace. And in fact, Paul Martin, the resident who's working with me, and I just yesterday morning saw a patient who had recently had one of these implanted, who was recently in the hospital. You can see these leads actually go deep within the brain in order to stimulate the areas of the brain directly that are causing seizures. So the next way that our patients can be treated, the next least invasive way, is by ablating the region of the brain that has been causing seizures. Obviously, one of the most common parts of the brain to lead to seizures is the hippocampus, and you can see that there is an ablation probe that's stuck from the occipital region, coursing into the temporal lobe with its tip at the anterior aspect of the hippocampus. Diffusion-weighted imaging for these patients, and these are often done intraoperatively. The imaging is often done intraoperatively. That is, like the patient has some ablation performed, and then some imaging is done, more ablation is performed, more imaging is done, in order to make sure that they're doing the ablation in exactly the right area and avoiding complications. So usually the diffusion images will show some restricted diffusion in the rim of the ablation cavity. You'll also see some avid enhancement in the rim of the ablation, and often some T1 hyperintense blood products, some as the coagulation happens in the region of ablation. So yeah, we use lasers. So visual ACE is one of the main techniques that we see here at IU. Interestingly, what's used in order to do ablation, laser ablation or thermal ablation, is MR thermography, which is something that most radiologists aren't tremendously familiar with. But what's happening in MR thermography is that first anatomic images are obtained, and then maybe similar to an fMRI, where we superimpose images upon the anatomic images, you can see that there are colored areas that are lighting up on this MR thermography image. Basically, what's happening is that as the protons in water are getting heated, that will actually change their relaxation time. So if multiple successive images are taken rapidly to look at the proton relaxation times in these areas of ablation, we can actually see those changes and see how hot, like how the temperature is changing in the region of ablation. And obviously, our surgeons are trying to avoid ablating a larger area than they intend. They want to restrict the ablation to just the area around the probe. Luckily, a lot of these areas are surrounded by CSF, which tends to dissipate the heat and decrease complications. Any large blood vessels in the area, that would be the thing that I'd be most worried about, I think, would be ablating a blood vessel and causing a giant hemorrhage. But in fact, the fast moving blood through a blood vessel tends to dissipate heat very nicely and prevent the accidental ablation of a blood vessel, of a large blood vessel. All right, so one of our most invasive things that the team will do is a temporal lobectomy, and many of the other techniques that I already talked about can actually be done before a temporal lobectomy, and a temporal lobectomy can still be performed. So, just because our surgeons have done a temporal lobe ablation or a hippocampal ablation, that does not exclude the patient from the possibility of a future temporal lobectomy if seizures continue to remain refractory. So the surgeons are typically going a specific distance back in the temporal lobe. They're usually resecting as much as they can of the hippocampus and amygdala, being primary seizure-causing organs. And sometimes you'll see small amounts of medial temporal lobe or small amounts of hippocampus that are left behind in the surgery. That's fairly common and may or may not be intentional, and may or may not be what the surgeon would ideally have liked to do, but maybe they knew that they had to because of some anatomic considerations. Another one of the surgeries that certainly can be performed is a lesionectomy. So if we see abnormal lesions within the brain parenchyma, the surgeons can go in there and actually do a smaller volume resection of an abnormal lesion that is suspected to be causing seizures. So here is that lesion after resection. There was a subtemporal approach used. The parahippocampal gyrus lesion was resected in this lesion. And you can see the encephalomalacia, but it's a lot more focal. And then if this patient went on to continue to have seizures, perhaps the team would consider recommending to this patient to get a temporal lobectomy in case there was some associated cortical dysplasia or abnormalities of the hippocampus that continue to lead to seizures. Hemispherectomy is not something that I see commonly at all, mostly because I primarily read adult patients and am assessing adults for their epilepsy, but it's a procedure that's done a lot more commonly, obviously, in pediatric patients, and these patients tend to do a lot better than you'd expect that they would do for having had a temporal or a hemispherectomy, mostly because if it comes to getting a hemispherectomy in a patient, chances are that hemisphere was assessed as not being very functional in the first place, and getting rid of it is not going to have a significant effect on the patient's activities of daily living. Okay, so let's talk a little bit more specifically about the role of radiology. So this first portion of the lecture, I wanted to talk, a little bit more about the multidisciplinary approach to seizures, and I wanted you all to have a little bit better understanding, even if it's like fairly superficial and bird's eye view, of how our neurologists and neuropsychiatrists and neurosurgeons and radiologists all approach a seizure patient and all the tools that are available and how we do all that. But now, again, in this second part of the session, I'd like to talk more specifically about some of the abnormalities that can lead to seizures. All right, so we're gonna do a few cases. I'm gonna pick on our residents just a little bit. It's only, I think Tanya said it was only a few 100,000 people listening, so no pressure. I might just go down our list a little bit and see what we see. All right, so let's see. Why don't I pick on Dr. Stephen Leonard? Are you available to tell me what you see on these images?
Yes, I'm here.
Okay.
So it looks like I see some thickening of the cortex, some increased T2 signal associated with that thickening on the right, and then the left I think is an ADC, and it's high on ADC.
So what if I told you that this patient had an MRI that was done a week before this that was totally normal, and then had a seizure, we re-imaged the patient, and these abnormalities showed up?
So this could be sequelae of that seizure. So you get gyral thickening from edema.
Yes, absolutely. And is the high ADC typical?
No.
No? So tell me about that.
So that means that there's some increased diffusivity of that area.
Yeah. So what would you expect?
I'd expect, low ADC.
Yeah, and there actually either one can be present in the setting of a recent seizure. So you can have, basically the seizure outstripping the blood supply's ability to provide oxygen to the cortex that's having seizures, especially in the setting of status epilepticus. So the patient is seizing, and they eventually have cytotoxic edema because the blood supply just can't keep up, or it may just be kind of a reactive, more vasogenic style of edema that we see in these patients, especially if it's a little bit less impactful of a seizure. Nice. Okay. Thanks, Stephen. All right. Let's see. Monali, what are you, can you tell me what you're noticing on these images? And by the way, we have trainees of all different levels and all different experience. Stephen, one of our fellows, actually participated with me in epilepsy conference last year. and Monali is a second year radiology resident. So yeah, a broad range of experience.
Hey, so I think here we're looking at the FLAIR images, and in the right, I guess temporal horn, I'm seeing some increased FLAIR signal, and then on the coronal view, I think that right looks more like we kind of lose the normal architecture. It kind of looks edematous, and again that increased T2 signal. So
tell me what you think.
I think I'd be concerned for like a temporal horn epilepsy, like especially with the distortion of architecture, the increased signal. I'd be thinking about like mesial temporal sclerosis maybe.
And I actually love that you mentioned that. Mesial temporal sclerosis is a process that we see like very, very commonly, and it's one of the primary things that we teach to our residents as a cause of ongoing epilepsy. So I love that that's like at the forefront of your mind as you think about this. One of the interesting things about this case, though, is that unlike most mesial temporal sclerosis patients, we're seeing, like you accurately described, some edema in that hippocampus, which would not be typical of mesial temporal sclerosis, which tends to be an atrophic process. So in this setting, I might be wondering about something similar to what Stephen mentioned last time. Maybe the patient had a recent seizure that caused some edema in this structure, or maybe the patient is having some sort of acute, more acute stage autoimmune encephalitis. Maybe there's can you think of any infections that like to affect the hippocampus, Monali?
I'm thinking like no, I'm blanking on the name.
Yeah, you're under pressure. No worries at all. So
herpes, herpes.
Okay, so herpes simplex might be another thing that we'd really strongly consider on this patient as well. Yep, with an edematous hippocampus. All right, nicely done. Here is this same patient showing some restricted diffusion in the cortex of the hippocampus. You can see that here again, and this happened to be a patient who was, and then no significant enhancement associated with that either. So that patient was just simply like acute seizures, having some edema in that region of the hippocampus. Nicely done. Okay, so let me see. I'm going to skip over our first year residents. So Wilfred and Wyatt, you're off the hook this time. Jared, can you tell me what you see on this case?
Yeah, let's see here. So looks like on those are the FLAIR images.
So we're looking this one, well, and the fact that I see like very little other structures outside of the brain parenchyma tells me that, and the fact that it looks like a crappy FLAIR sequence tells me it's probably the diffusion weighted images.
Right.
Okay. Yes, and then the second, what do you think the second one is here, given the bright CSF?
Right. So the bright CSF, I think that is a T2.
Okay. All right. What are you seeing?
So on the restricted sequences, there's some increased signal within the left kind of temporal horn, kind of in the same area that Monali had. Maybe that's hippocampus.
Yeah.
And it seems like it's kind of a rim of diffusion, not so more homogeneous.
Yeah, so exactly. And it actually looks very similar to Monali's case, right, where there's that rim of cortical restricted diffusion and maybe some additional restricted diffusion, but certainly some DWI hyperintensity. On your case, it looks maybe a little bit more widespread, but very similar. Yeah, I agree. Okay. Tell me more.
Right. And then a little bit more inferior to that, I don't know, if you're seeing on the T2 images, there's some increased T2 signal within the, I don't know if that's the frontal parietal cortex as well, but it's asymmetric to the contralateral side.
Yeah, so there's a lot of T2 hyperintensity, and I love that you're noticing all this stuff even around the occipital horn of the lateral ventricle, going into the white matter of the temporal lobe. Okay, so tell me about that. What do you think?
Right.
What in the world is going on here?
What in the world is going on here? I don't know. A white matter kind of demyelination, or considering the restricted diffusion.
Mm-hmm.
I don't know, seizures cause restricted diffusion.
Yeah,
but there's
they
also,
definitely can.
right. There's other things that can cause restricted diffusion. I don't think this would be a repeat case of mesial temporal sclerosis.
Okay.
So I don't know, maybe it could be an infection.
Okay, I think that's a very reasonable thought. Yeah, so maybe some sort of like, again, maybe a herpes simplex or something like that. Tends not to affect the white matter as much. This happened to be a case of a diffuse infiltrative glioma. And you know, we're seeing just a lot of weird white matter involvement, weird cortical involvement. It's spread throughout that whole area, and even more widely than the hippocampus. But maybe some of this restricted diffusion within the hippocampus is related to the seizures that the patient was having from their glioma that was involving the hippocampus. So I've seen at least a few cases of this where there is a more widespread abnormality. The radiologist interpreting the study, their attention was drawn very heavily to the hippocampus, and they wanted to make a single diagnosis, and yeah, went down this route of infection or something like that, when in fact it was just a glioma, but causing seizures that showed up on the restricted diffusion on the DWI images. All right, nice, thank you. All right, let's see. Chris, can you tell me what you see on this image here?
All right, looks like we got a axial flare.
Mm-hmm.
And let's see. I think the only thing that really stands out to me is the increased flare, T2 flare signal along the splenium of the corpus callosum with some white matter involvement posteriorly into the occipital lobe and a little bit around the occipital or around the atrium of the lateral ventricles.
Mm-hmm. Yeah, so focusing on that abnormality in the splenium, have you ever seen that before or know what that might be?
I have seen it, but I'm blanking on what causes that.
Mm-hmm. Yeah. There are actually a lot of things that cause this lesion, and also a lot of names for it. So anytime something has a lot of names, I feel like it's even harder to remember any one of them.
The white matter, I don't remember the name. The white matter involvement itself would make me think, a demyelinating lesion could certainly be part of that.
Mm-hmm.
It crosses midline, but it looks so symmetric that I wouldn't necessarily put. I guess I couldn't rule them out, but like gliomas or lymphomas would be lower on my list based on that look. It doesn't really look mass-like. So
yeah. So let's say this patient is a chronic epilepsy patient, and they had a study, say again, like a week ago, that was totally normal, and then they came in with more seizures, and now we're seeing this study.
I'm drawing a blank.
Yeah. So this is a good example of something that's referred to as either a transient splenial lesion. I think Radiopedia has it listed as a cytotoxic lesion of the corpus callosum, CLOCC, clock. And it's actually fairly common to see this in patients who were on seizure medications, but for whatever reason have stopped their seizure medications and started having seizures. It's kind of strange, but we will see this weird lesion in the splenium of the corpus callosum as a result of them stopping those seizure medications. Like, kind of weird. But there are a number of other things that can cause these lesions as well. One of the other big ones is a lot of like chemotherapeutic agents can do this, and like there's a big long list of things that can do this. But in the setting of epilepsy, think strongly about a patient who recently stopped their meds. Nice. Here's another example of one that's a little bit less extensive. You can see that small lesion right in the center of the corpus callosum in a different patient, if you can read through all the motion. All right. Let's see. Who else should I pick on? Dan, can you tell me what you see on this image?
Sure, we have a T2 image, and it just looks to be a little bit more lumpy, bumpy in regards to the gyri, as well as the calvarium itself, I mean, I feel like there's a few areas, like maybe like the right insular cortex looks a little bit thickened to me, and there's some asymmetry between the lateral ventricles, and again, like the caudate nucleus has like a little bit of a lumpy bumpy appearance, and then
let's say a lot of that as you scroll through it looked like a little less abnormal, like given just the constellation of images as you scrolled through. So go ahead and just like ignore the brain parenchyma itself.
Ignore the brain parenchyma. Okay. Just maybe the calvarium itself looks thickened.
It does, yeah. Do you know why I might be showing you this in an epilepsy conference?
Isn't it in the sense of like there's just diffuse like volume loss during development, then the cortex can end up like just thickening given that potential space?
Yeah, so you can see that in the setting of some asymmetric atrophy syndromes. What is the Dyke-Davidoff-Masson? Is a pediatric, usually a pediatric insult to a single hemisphere that can cause compensatory hypertrophy or thickening of one side of the skull. I don't see it that commonly in the setting of just like brain atrophy. Usually the skull itself just like stays normal thickness, doesn't like compensatorily thicken up if it's like the whole brain. I definitely have seen it in the setting of chronic shunting, where there's decreased intracranial pressure chronically, then areas of the calvarium thicken up. But that was not the case for this patient. Any other ideas? There's one other thing that patients so oftentimes these patients, if you look 20 years ago, they will have had a normal thickness of the skull.
No, I'm not sure.
So there are certain seizure medications that tend to cause calvarial thickening over time. So oftentimes these seizure patients, like basically I wanted to show you this in case you hadn't come across it before, just so that you don't need to go down all these rabbit trails of trying to figure out why the patient has a thickened calvarium. If they have epilepsy and they've been on medications for a long time, like that's probably it and nothing to worry about. All right. And actually, let me point out, especially for people who aren't used to looking quite as often at MRI or haven't looked at as many, where we're even talking about the calvarium. So remember, the outer layer of brightness on a fat, bright sequence is usually the scalp. We'll usually see a dark layer of outer cortex of the skull, so the outer table, and then we'll see the fatty marrow. And then we'll see usually a slightly thinner inner cortex of the skull. So this whole area right in here is all marrow, much thicker, like Dan pointed out. And then this whole area right here, that's thicker than normal. Like the temporal bone is supposed to be, squamous portion of the temporal bone is supposed to be fairly thin. So we're seeing a much thicker calvarium than we expect. Okay, nice. Let's see. Let's go back to Stephen. Oh, did Stephen leave? Let's see. Looks like we lost Stephen.
I'm here.
Oh, you are? Okay. What do you see? What do you see on this case?
So I see some compared to at least the temporal horns, the cerebellum is quite atrophic.
Mm-hmm. Definitely. So markedly atrophic cerebellum. Why am I showing you this in the setting of an epilepsy lecture?
Because this is, I think, very commonly seen with chronic epilepsy medications.
Yes, absolutely. And in fact, not only do epilepsy medications cause cerebellar atrophy, but epilepsy itself, even patients who are not well controlled with medications or who have not been on chronic medications can have some degree of cerebellar atrophy. There's one other thing that I think about, especially in the setting of an unexplained epilepsy. Now seizures don't usually come from the cerebellum, so this would be much lower down on the differential list. But there are a lot of autoimmune encephalopathies, especially those. There's one or two that are associated with as a paraneoplastic syndrome with breast cancer that can have cerebellar atrophy as one of the manifesting imaging findings. So that's something to keep like in the back of your mind, even though if it's a chronic epilepsy patient, chances are it's just from seizure medications. Nice. All right. So there are a lot of diseases. So we looked at a lot of the things that are associated and kind of incidental when it comes to epilepsy, a lot of those imaging findings. Holy cow, are there tons and tons of imaging findings that can be seen with epilepsy, many of which cause seizures and are seen easily on imaging, many of which aren't. But certainly anything that can cause any sort of encephalomalacia, whether it's trauma or stroke, diffuse hypoxic ischemic insults, infection, anything that's damaging that cortex can ultimately lead to seizures. And if we wanted to go into the details of all these different abnormalities, this would be a several days long lecture. So we're not going to do that for sure. In fact, one of the more surprising ones is even Alzheimer's disease and other dementias, because they are primarily cortical damaging processes, do tend to be associated with seizures. It's pretty interesting that our dementia patients can present with seizures just as a result of the dementia itself. But again, like most of these things, we're not going to go into right this minute. All right, so we're going to look at a couple of non-gliotic epileptogenic lesions. Okay, just as a reminder, this is an image of our hippocampus. You can see why it was called that, hippocampus. We're looking at something that is a horse monster, and it has this sort of a shape to it. When I look at it on coronal images, typically, so we're looking at a cross-sectional slice of the hippocampus, and you can see how the hippocampus folds around. So this is parahippocampal gyrus right here. And just as a detailed look at the anatomy of the hippocampus, we can see layers of gray and white matter that fold around upward and inward and kind of curl in like this. This is a very typical and classic and normal appearance of a hippocampus, where we're seeing those layers. We're seeing the volume of the hippocampus basically fill the temporal horn. You can see the bright CSF of the temporal horn immediately adjacent to the hippocampus. And the reason that I'm showing you this is that when a radiologist is assessing a patient for chronic seizures, one of the main things they need to focus on is the hippocampus. They need to know whether there's abnormal atrophy or abnormal, like Manali was talking about earlier in the conference. Have we lost architecture? Do we have too bright of signal? And is the hippocampus atrophied? So this is another view of the hippocampus. Like I said, this is parahippocampal gyrus, and there are definitely like anatomic components of the hippocampus that we can name even more specifically if we see lesions in any of these specific areas of the hippocampus. You'll have a little bit of choroid plexus that's very common to see above the hippocampus. Don't get confused by enhancing choroid plexus, thinking that it's some sort of pathologic lesion. I've seen that happen many times. And then this is the choroid fissure containing CSF, and the temporal horn also containing CSF and wrapping around the hippocampus. So if you see a lesion in a specific part of the hippocampus on cross-sectional imaging, you can certainly talk about it.
We lost you, Aaron.
Like 5 minutes. All right, I've got to leave in just a little bit. I've got to take a break in the middle of some of these cases, but we'll probably take a break in just a couple minutes here.
Okay, sure.
Okay, so let's see here. All right, so we looked at this hippocampus. I want to look at both hippocampi side by side. I think that it's always useful to do a little bit of a comparison. And let me see who's on, and I can ask. Actually, Manali, since you're our hippocampus expert now in the conference, what are you noticing with that contralateral hippocampus that's different?
On the left, it looks kind of like the architecture is distorted. I've heard it described like as a reversed S, and this just looks a little more, I don't know, like chunky. I don't know if that's the word, than the opposite side.
I totally agree. It looks almost like balled up. It doesn't look like it's laying flat like the normal hippocampus. And the collateral sulcus is much more vertically oriented. Have you seen this before or know what this is? If not, I wouldn't be surprised at all. Not because it's you, obviously, but because it's not something that many of our residents have come across. Any ideas? No? So this is something that's referred to as either hippocampal malrotation or incomplete inversion of the hippocampus. And because we almost always used to exclusively see this on our epilepsy workups, we figured that it was associated with epilepsy in some way. There was a nice article that came out a few years ago where the title of the article was something to the effect of hippocampal malrotation is a benign entity and not associated with seizures. And I love that as a title. Like the authors made sure you didn't even have to read the article. So this is a finding that's incidental, we'll see sometimes, and I think is pretty easily confused with mesial temporal sclerosis. Yeah, here we go. So is an anatomic variant, has no clinical significance in MR negative temporal lobe epilepsy. I love it. When I publish, I'd love to have titles that look like that. Okay, let's see, who should I pick on next? Chris, what do you tell me about this case? What two sequences are we looking at here?
All right, so I think we've got the coronal oblique cuts, and we're looking at I think a stir on the left and a flare on the right.
Mm-hmm.
So we're mostly focusing on, I mean, these are designed for the hippocampal cuts. So the biggest thing I see is bilateral signal, abnormal signal. Looks like maybe slightly brighter on the left. And then there's also maybe some bilateral architectural distortion, honestly, on the right. May just be resolution.
Yeah, I totally agree. And I mean, this is a great example of, I don't care whether it's a 3T or a 1.5. This patient was moving all over the place and it just made it look terrible, right? And a lot of that loss of internal architecture is probably just because we've got really crappy images. I would be very tempted to just refer to this as a unilateral process and just chalk up most of what we're seeing on the right as just like really bad images. Yeah, okay. So tell me about that.
Yeah, so definitely on the left, right signal, loss of the normal architectural pattern there. It doesn't look like it's malrotated relative to that prior one, though. This looks like the normal S shape.
Yep.
So, I mean, I don't know that I see anything that's necessarily specific to this case that leans me out of the normal mesial temporal sclerosis discussion, though. It doesn't look too atrophic compared to the right. It's mostly just the architecture and the signal.
So I would argue that on the coronal stir, we're seeing too much CSF, which is our usual clue that there's a little atrophy. Yeah, sometimes the flare does not really show that atrophy nearly as nicely as the coronal stir does. So in fact, that's one of the biggest reasons that we're getting both of these sequences. We're using the coronal stir to look for atrophy, and then we're using the coronal flare to look for abnormal signal intensity. So I love that you're drawing that signal intensity out on flare. Yeah, and you're absolutely right. This is a case of mesial temporal sclerosis, just like run of the mill. Probably the seizures are coming from this patient's hippocampus. But remember, mesial temporal sclerosis does not show up in our earliest patients with seizures. This is something that tends to develop over a longer period of time. And this is which came first, the chicken or the egg scenario. Does the mesial temporal sclerosis come from seizures? Yes. Does mesial temporal sclerosis cause seizures? Yes. And in fact, if we take out the hippocampus in our patients or ablate the hippocampus in the setting of mesial temporal sclerosis, oftentimes that cures our patients or at least significantly reduces the number of seizures that they have. So there is a complex interplay between cause and effect when it comes to mesial temporal sclerosis. And here's that hippocampus. Here you can see it on the axial images. Sometimes they show up nicely on axials. Sometimes we only have good axials. So make sure, especially in a seizure patient, you're also paying attention to the hippocampus on the axial views. Even in patients who have a good coronal, because you do want to train your eye to find where the hippocampus is located on an axial study in addition to the coronals, because that can be a little bit harder to get used to. There is a big chunk of these mesial temporal sclerosis cases that are detected by MRI. So 95% tend to be detected. And it's present in a huge percentage of patients with temporal lobe epilepsy. So the most complicated cases that I'm dealing with are those where we couldn't find an abnormality. But MTS cases often don't even come to our multidisciplinary conference because it's such a straightforward management plan. A lot of these patients also have dual pathology. There is an associated, small low-grade tumor with it or some other abnormality that has led to the mesial temporal sclerosis. All right. These patients tend to be refractory unless surgery is done, so refractory to medications. And like I said earlier in the lecture, many of these patients have had febrile seizures as a child. In fact, if they have not had febrile seizures as a child and you're wondering whether there's mesial temporal sclerosis, that may be a factor that would make you lean in the direction of not calling MTS. And if they have had febrile seizures as a child and you see a questionable abnormality, that may make you lean in the direction of calling MTS. All right, so we're going to take a break there, about a 15-minute break, and go ahead and stretch your legs, do what you need to, and we'll be back with a few more cases and a few more causes of epilepsy in just a little bit.
Yes, sounds good. Yep. Thank you, Aaron.
So let's see. So Wes, why don't you, since you've escaped notice so far, like tell me what you're seeing on these images. We can kind of hear you. Let's see. Tanya, you said Wes was on here, and now
He on the list.
Can you hear me? Can you hear me?
yes. Yay.
Yeah, sorry, my AirPods weren't connecting.
Oh, got it.
Sorry.
Got it.
Yeah.
All right. So tell me what you see.
Okay, so a coronal flare and a coronal T2-weighted sequence. I see that there's volume loss. It looks pretty symmetric. I mean, maybe there's a little bit of asymmetry, but overall pretty symmetric. There's a focus of increased signal on the T2-weighted sequence within the pons with surrounding gliosis, maybe a prior infarct. The temporal lobes, looking at the hippocampi in the region of the temporal horns and choroidal fissure. I mean, there's maybe some asymmetry on the right. Maybe the right temporal horn slightly bigger. Maybe the left hippocampal formation. I mean, maybe there's some volume loss or change in architecture. The right amygdala looks a little bigger.
Yeah, that may just be cut. Okay, yeah, I totally agree. So if you had to give mesial temporal sclerosis on one side, which would it be?
The right.
Yeah, I totally agree. It looks like we've got some hyperintensity of the hippocampus there. Mm-hmm. And one other finding is how smooth the top of the hippocampus looks. So the left one has these normal looking lobulations. The right one is very, very smooth. And I love that you notice that, there's like the atrophy is pretty significant. We don't see any real good internal architecture, although maybe that's just a function of the quality of the imaging, because I feel like we can't see that very well on the left either. Totally agree. And then when we look at the axial images, again, like we're trying to pay attention to the hippocampus on the right. And it's interesting to me. Yeah, you're pointing out, you were pointing out that amygdala on the right. And I said, maybe that's just cut, but do you feel like that finding that you noticed pans out at all on these images?
Probably.
Okay.
Yeah. Yeah, I mean, I think so.
So for those who aren't as used to looking at the amygdala, this is the region of the amygdala right here. And you can see that same region on the contralateral side is much smaller. So, so this patient has a much larger, like asymmetrically larger amygdala on the right. And it seems like even though the amygdala is bigger, the hippocampus is smaller. So we have a look for mesial temporal sclerosis on the right, but then like Wes was noticing, even on those first few images, the amygdala is a little bit larger, actually maybe quite a bit larger on the right than it is on the left. Okay, so this definitely happens sometimes, where we'll see, sometimes it's mesial temporal sclerosis and the amygdala on that same side is also atrophic as a result of the chronic seizures. But sometimes there's something in that amygdala that is actually causing the seizures. And in that case, you may see an amygdala enlargement with a same side mesial temporal sclerosis as a result of the seizures that have occurred. When an amygdala is biopsied, when it's resected and biopsied, sometimes there'll just be dysplastic tissue in there, like a cortical dysplasia. Sometimes there's a low-grade tumor in there, but typically these things don't grow. Interestingly, if a patient has received chronic epilepsy medications and their seizures are well managed, the amygdala enlargement tends to reduce over time. So sometimes on subsequent imaging, that finding will not be nearly as evident as it was in the initial imaging. So it's a very kind of a curious finding. All right, nicely done. Okay, so let's see. I don't know who I haven't picked on quite as much. Let's see. Jared, can you tell me what you're seeing on this flare image?
All right. So in the flare image, we're getting more kind of at the level of the floor of the mouth, I imagine.
Yeah.
Yeah.
Why?
So, yeah. I expect with like seizures would be more kind of brain parenchyma. I know with
Yeah. Seizures
brain,
don't often come from the mouth, do they?
right. Yeah. But I'm noticing some increased signal on the left kind of floor of the mouth. I think that's
Okay.
I don't know, the lingual space.
Okay.
But the brainstem itself looks okay to
Yeah.
me. I'm not
And I'll tell you, we're actually cutting through the level of the tongue.
of the tongue. Okay.
Yeah. So thinking back to your med school days, why might I be showing you some imaging of the tongue in an epilepsy patient?
Can they bite their tongue?
They can absolutely bite their tongue. So sometimes if there's a question of, if you like so many of us are when we look at epilepsy cases, sometimes we're a little skeptical, wonder if the patient really does actually, I don't know, a lot of radiologists get this way on all cases. We read so many normals that we wonder, like, is there actual pathology, or is the clinician just doing a shotgun approach screening for any sort of disease? Well, this is a really strong indicator that there is real disease, right? Patients with pseudo seizures tend not to bite their tongue. And it also may indicate that there's been a fairly recent seizure too. Okay, so Jared, tell me what you're seeing on this image.
All right. All right. Yeah, both of the hippocampi look a little bit more architectural distortion to me.
Yeah, and maybe part of that is that we are actually anterior to the hippocampi.
Here to the hippocampi. Okay.
Yeah.
So for anterior to the hippocampi, is that kind of where the amygdala also lives?
It is. Okay. Yeah. Every
So
once in a while, I show a duplicate or sister case.
right. Okay. So maybe there's some amygdala enlargement, but I don't know if one's more asymmetrically enlarged than the other.
If you had to give a side, which would you pick?
I mean, I'm leaning more towards the left side being larger.
Yeah, I totally agree. That looks a little larger to me too. Absolutely. Okay. So this I think it was this case that I had mentioned to the referring physician, or I had mentioned in my report. I said that there's increased size of the hippocampus on the left, or increased size of the amygdala on the left, highly suspicious for isolated amygdala enlargement as a cause for the patient's epilepsy. In that neurologist's report, he had noticed that the right temporal horn was bigger than the left, and being very focused, like a lot of us are if we haven't looked at a whole lot of epilepsy imaging, he was very focused on diagnosing mesial temporal sclerosis. So the neurologist said in his report, right mesial temporal sclerosis. And then because he had looked at the images, and then he put in parentheses, curious neuroradiology finding reported as isolated amygdala enlargement. So he basically was calling me out in his report that he didn't believe me. But then a few weeks later, I followed up on the patient and found that there was an EEG that I felt good that had vindicated me, that had found seizures coming from the left temporal lobe. This is a very real entity, even though it's not super common, it's something to be aware of. And there are some definite, very good articles talking about this as a real cause for seizure. So just be aware that isolated amygdala enlargement, not super common at all, but something to be thinking about in the back of your mind. Nice, Jared, thank you. All right. So, oh no, this was the case. This was the case that the neurologist had done that on. So that was the story there. And you can see the clear the amygdala enlargement on the left, but you can understand why someone who's like really looking for mesial temporal sclerosis might see that temporal horn enlargement and think that this is the abnormal side. All right. So, we talked at length here about the medial temporal lobe. We talked about mesial temporal sclerosis, the amygdala. There are some congenital abnormalities that I think we should all be aware of and clued into to diagnosing as well. And one of the big ones with multiple categories is that of cortical dysplasia. So we'll look at some examples of cortical dysplasia, but basically there are three main types. Type 1 is sometimes visible on MRI. It's more often associated with cortical thinning than it is with thickening, but sometimes thickening. And it is associated with cortical blurring. And it tends to be a much larger region, which can make it, because it's a little bit more subtle and a little bit larger area, more difficult to focally identify. Sometimes the biggest thing you'll notice is these abnormally shaped or sometimes very deep sulci. So type 1 is not one that we come across quite as frequently because it can really blend in with its surroundings. All right. So here's an example of a type 1. It's a larger region. You can see that the white matter in the region is a little bit more hyperintense, and the cortex is a little bit thickened. There's a little bit of blurring of the cortex, and the anterior temporal lobe is a common place to find this abnormality. And sometimes you just have to be really clued into the fact that the patient is an epilepsy patient. And if they have an EEG, you really should be aware of where the EEG is localizing. And if it's a temporal lobe, pay very close attention to this. Sometimes I feel like I have a hard time seeing the cortical thickening and cortical blurring, but that the white matter abnormality is a little bit more evident. So compare, when you're looking at the temporal lobes in an epilepsy patient, compare side to side the temporal white matter, especially on either a T2 or a flare sequence. Sometimes you'll see how nicely dark the white matter is on the normal side and how like muddy or dirty or hazy it looks on the abnormal side. All right. I like this article a lot. It was a good review of a lot of different types of dysplasia, especially in pediatric patients. The pun is a little weak, I think. A tip to find the abnormality, because they're talking about temporal tip dysplasia. Not a huge fan. But again, a good review article nonetheless. All right. Type 2 is one that we do much more typically see on MRI. Okay. This is more often associated with cortical thickening and blurring, and oftentimes we'll see what's called a transmantle sign that indicates that we're looking at a type 2B or Taylor type cortical dysplasia. Let's see. So here's an example of a couple of different sequences demonstrating this abnormality. You can see it like a very clear flare hyperintense subcortical abnormality that trails off toward the ventricle. So that transmantle, the mantle being, the substance of the brain, the white matter of the brain, you can see that transmantle sign as the abnormal neurons that were migrating from around the ventricles out to the cortex early in development. You can see where abnormal neurons kind of were left behind and set up shop. And your seizures are most often coming from the abnormal cortex that's more superficially in these cases, but there is a possibility of seizures coming from deeper down, especially if the neuronal connections are still in place to attach these neurons eventually to other areas of the brain that can be epileptogenic. All right. This is actually the first case of cortical dysplasia that I interpreted. I'm actually not 100% sure that it's real even now, even these days, but I remember as a resident being taught on this case. And I looked back in the dictation system, and sure enough, like whatever 13, 14 years ago, I was reading this case with one of our senior pediatric neuroradiologists who thought that there was a little cortical thickening here and then a little bit of flare hyperintensity immediately adjacent to the cortex that showed up here, not just on the T2 images where it could easily be mistaken for dilated perivascular spaces, but did also show up on our flare images as an abnormality that could indicate some of that Taylor type, starting to get into the white matter looking like a transmantle sign, although not all the way across the white matter. All right, let's see. Who else should I pick on? So let's see.
There are 2 pages that you can choose from.
Okay. So many people. So Wyatt, I am going to pick on you, even though this is your second day of neuroradiology. You've only done one day. Can you guess which sequence we're looking at here?
Let's see. So the gray matter looks lighter than the white matter, and the CSF is dark. So I think this is flare, maybe?
You got it. Yeah, this is a flare. Okay, so are you seeing the asymmetric abnormality in this patient?
Yeah, so it looks like anteriorly on the left, it looks like in the white matter, it's a little more, I guess, hyper intense compared
absolutely.
to the contralateral side.
Okay, and how would you describe this in some of the terms that I just was using in talking about this abnormality that's epileptogenic?
Yeah, so I guess maybe some cortical thickening, perhaps, and I don't know if this is like the transmantle sign you were describing.
Yep, absolutely. So we're starting to think about a type 2 cortical dysplasia here. Absolutely. Yeah. Nicely done. All right. Okay, and here is an example of that, or this is actually the same case. You see how like slightly dysplastic the cortical folding looks and how that abnormality like kind of triangulates down toward the ventricle, and a little bit of cortical thickening and blurring throughout that whole area. Nicely done. Okay, let's see. Tony, are you taking cases?
Yes, I'm here. So we have an axial and sagittal T1.
Yeah.
Kind of seeing diffuse global volume loss predominantly there in the around the central sulcus, more so than the rest of the brain. It's bilateral. It looks symmetric. I'm not really seeing any like infiltrated process or anything.
No, I agree. And this is just a chronic seizures patient.
Oh, okay.
Don't worry, I'm not like switching gears completely.
So yeah, it's kind of what
I love that you're taking some time on this, because these are often very difficult to identify. The abnormalities are very difficult to identify. What if I told you the EEG is localizing kind of to the right frontal lobe?
Right frontal lobe.
It's still a challenge. And I would say the patient is having like some hand motor seizures. So I'm gonna clue you into where the abnormality is, and holy cow, like this was a case that was missed on multiple reads. So like you should absolutely not like don't feel like this is an easy to detect abnormality. So here is where we thought the seizures were ultimately coming from. Okay. Right there.
I mean, when I'm comparing
like
side to side, yeah, it looks, I guess it's blurring a little bit. Yeah.
Yeah. It's terrifying, isn't it? These are so hard. These are so difficult to see. Yeah, and maybe like a little bit of cortical thickening through there, maybe a little bit of white matter blurring through that when we look at it in the same spot on the sagittal view. So yes, so thank you so much for like not being able to find this, because that's because that's exactly what these cases are like. And sometimes we have the EEG that directs us a little bit, and even in that setting I've seen cases be overlooked time and time and time again. So yeah, these can be very subtle abnormalities, and sometimes it's embarrassing. Like I've had this before where a neurologist will say, hey, did you think there was cortical dysplasia on the other side, you know, like right over here or something, and I'm like, yeah, it's there. Yeah. So sometimes, you know, once it's pointed out, it's a little bit easier to see, but holy cow, these are difficult. So, all right. Thanks for being my guinea pig, Tony. Okay. So, type 3 is a type of cortical dysplasia that is associated with other lesions. So if you see MTS, if you see a tumor of some sort, if you see a malformation, sometimes those are associated with cortical dysplasia. And then in that setting, the dysplasia is referred to as a type 3. Okay, this is a case that I showed earlier as a lesionectomy. You can see the flare hyperintensity, you can see the enhancement, and this lesion was chopped out. And once it was chopped out, it was found to be a ganglioglioma, which is one of the most common low-grade primary brain tumors of the temporal lobe, causing seizures that I've seen pathologically proven. So ganglioglioma. And then there it is again, the lesionectomy changes. So actually, before I move on from that, there are a couple other tumor types, the PXA, pleomorphic xanthoastrocytoma, that is supposed to manifest early on with seizures. I don't see those very often at all. And they're usually a lot larger than the gangliogliomas that I see. And then the other tumor type that's even questionably a tumor is the dysembryoplastic neuroepithelial tumor. It's so low grade that again, there's some question about whether it's a tumor or just a malformation of some sort, but tends to have like more of a bubbly and triangular appearance that also is associated with seizures in some cases. Okay. Some other malformations. Let's see. Why don't I have, let's see. Stephen, why don't you take this case?
All right. So what I'm seeing is just diffuse thickening of kind of the cortex, like all throughout. I mean, this is more, to me, like the frontal lobes mostly, like a lissencephaly type of a spectrum. It's just so diffuse bilaterally.
Yeah, absolutely. So there's almost like a smoothing of some of the cortex, and I agree, it looks almost thickened. Could I convince you that there might be a layer of white matter in here? Maybe just like a thin layer of white matter.
Band heterotopia then. Yeah.
Band heterotopia, absolutely. Okay, do you see any other abnormalities besides this diffuse band heterotopia?
Maybe along the right lateral ventricle, maybe superior to the caudate, maybe that there is some nodular heterotopia, very subtle.
Like up here?
Yeah.
Yeah, that ended up being a nothing when we scrolled through it. Yeah. What do you think about the hippocampi?
So the right one looks a little bright, big, a little flattened.
Yeah.
I don't really see that normal architecture.
I agree. So maybe what?
So I mean, maybe there's band heterotopia and right mesiotemporal sclerosis.
Yeah, absolutely. And what do you think about the anatomy of the left hippocampus?
It's not normal. I don't think there's quite, maybe it's just incomplete inversion of the left hippocampus.
Yeah, you got it. So we've got a band heterotopia, a right mesial temporal sclerosis, and a left hippocampal malrotation, or like you said, incomplete inversion. So yeah, this is one of those like think you're doing totally fine, but there's like a lot going on in the background that you may not be noticing. And I think it's a good idea to complete your search pattern even on a case where the abnormality is fairly diffuse, and you may be able to localize something that's a little bit more focal that's potentially amenable to some treatment. Nicely done. Okay, let's see. I'm gonna ask, let's see, Chris, can you talk about this case?
Yes, we've got, looks like axial and coronal T2s. Let's see, I want to say we've got absence of the corpus callosum here, a little colpocephaly.
Yep.
And then
So there's
like
already some maldevelopment issues going on. Yeah, definitely.
Yeah, and then definitely something happening with the cerebellum, like a cleft there. I don't know. This would be in probably not Dandy Walker, but maybe in like a Blake's pouch spectrum. Or,
Yep. And I'm gonna say, let's not talk about that right now.
Yeah,
that sounds like Pete stuff.
Fair.
Yeah.
So I think on the axial, what stands out to me is it may just be the cut, but the putamen and the caudate look a little dysmorphic, and so I still see the anterior limb of the internal capsule running through, but they just look a little dysmorphic to me. The gray matter there doesn't look quite right. Probably what stands out more though is along the walls of the lateral ventricle. We've got several nodular lesions that are following gray matter on, well, I guess I can't say on all sequences, but on these two sequences, it's following.
Yeah, exactly.
And then we see that really well in the coronals there. I don't think we're getting the hippocampi on any of these. We're too far back. So let's see. Yeah, I think that's what mostly stands out to me. So this would be probably multiple foci of nodular heterotopia.
Yep, absolutely. We've got nodular heterotopia going on. And I love that, like, you were talking about like all these other malformations first, because this is a great example of a case where there's so much going on that I've seen in the past, like many gray matter heterotopia cases get lost and not described. Like the heterotopia is not described because of everything else that's going on in the brain, and it's a subtle abnormality in a lot of our cases. So like you found it, like you definitely found it, but like your eye was drawn to a lot of other places because there's a lot going on in this patient. And in fact, Wyatt, when I was staffing with Wyatt just yesterday, we had a case where there were some nodules a little bit separated from the ventricle that matched cortex, that matched gray matter on each sequence, that we suggested maybe could be gray matter heterotopia as well. But Wyatt, especially for your information, like this is what it more typically looks like as Chris was describing, like right along the ventricles like this. Nicely done. Okay, so we'll do, let's see. This case we're gonna, I think, skip over because it wasn't as interesting, but there was a lot of focus, or I'll just talk about it. There was a lot of focus on this lesion in the right thalamus, and we kept getting distracted by that. And that's the case with a lot of epilepsy patients. You're looking for such subtle abnormalities that it's very easy to get distracted by one abnormality. It's very rare for a thalamic lesion to be causing epilepsy. And while we were focusing on that lesion, there was something sneaking up behind us that we didn't notice. And actually, you can see this kind of strange folding of the cortex, almost like a polymicrogyria at the back of the sylvian fissure here that we just really weren't noticing, and that ended up being the cause of the patient's seizures. So again, these abnormalities can be very, very subtle. All right, I think we have time for one or two more cases. In fact, this is one of my favorite diagnoses, and I'm going to ask, let's see, I'm going to ask Dan if you can talk about this here.
Sure. So we have a kernel T2 weighted image. Just scrolling through the.
What's the most conspicuous? Yeah, exactly. So we've got an empty cella here. That's the most obvious abnormality. Okay, but that's probably not causing seizures, obviously. So are you noticing anything else?
Are we able to scroll? It seems like you're kind of highlighting the region of like the gyrus rectus and the olfactory sulcus.
Look at the temporal lobes more.
Okay.
That's all I have for you. And this is a weird set of cuts, right? Because I'm not showing you the hippocampus. I'm not really focusing on the optic nerves or nerve sheaths like you'd expect if you're going down the route of idiopathic intracranial hypertension, like I'm sure you've been thinking about with that empty cella. So yeah, are you noticing anything weird about the temporal lobes? This is a diagnosis, if you haven't seen much of, like definitely flies under the radar for most radiologists.
See anything's really jumping out at me too much. I don't know, maybe just on the right side, the gyri look like it's a little bit more nodular than the left.
Yeah. And like so many of these cases, like I've seen people especially when you get an EEG that's directing you to a specific side or a specific region, then you start questioning everything. So let me draw your attention to the spots that I'm looking at. I'm looking at there being a little brain parenchyma that comes down here.
Yep.
Yeah. And then I'm also looking at all these little like weird bubbly things, even a little brain parenchyma poking into one of these things. Okay.
Yeah, it goes along with the intracranial hypertension now. So
yeah, exactly.
Is it just we're seeing a bunch of encephaloceles kind of protruding through the probably like tegmen.
Yeah, like greater wing of sphenoid, basically.
Okay.
Like poking into the anterior aspect of the middle cranial fossa. That's the place that I most commonly see them, like into the greater wing of sphenoid. Here's a big one. This is a different patient. You can see that poking down in there. And as this brain parenchyma pushes down into these defects within the bone, it is probably getting injured to some degree and ultimately can contribute to seizures. On CT, you'll often see small defects that represent the areas of the cephaloceles. Here are these little bubbles. Sometimes they obviously contain brain parenchyma. Sometimes they only look like they contain a little bit of CSF, and it's hard to tell whether there's brain parenchyma in them. And here's a little, frontal cephalocele that is less common to cause seizures. So this is something that I want to make sure that just all of us are aware of, that these temporal lobe encephaloceles, so we call them just simply cephaloceles if we're not sure if they contain brain parenchyma. If they definitely do, you can call it an encephalocele. And those are much more suspicious as epileptogenic lesions. But these are potentially resectable. The neurosurgeons, when they talk about these, talk about how when they go in to resect, they actually see that the brain parenchyma and the dura is all matted down into the region of the bone. So getting it away from the bone is a little bit more of a difficult process than it is for a patient without these temporal cephaloceles. So it is actually a fairly common cause of seizure, and it does seem to be associated with evidence of intracranial hypertension, whether or not those patients have other clinically manifesting symptoms of idiopathic intracranial hypertension. All right, well, since it's 9 o'clock, I'm going to stop there with cases. I think we've had a chance to see, like I talked about early in the lecture, a good overview of how seizures and epilepsy tends to be worked up by a multidisciplinary team. And then subsequently, we talked about a lot of the imaging features of causes of epilepsy and sequelae of epilepsy, some of which are a little less common, but you should still be aware of, and I see fairly commonly in epilepsy conferences. Thanks so much for everybody's time.
Thank you so much, Aaron, for the comprehensive reviews. Do we have any questions from the audience here? Seems like you make it clear. Yeah, so don't forget to a text for the CME credit that we have for the IU people, and for Thai people, we also have, we're gonna send an evaluation form to you guys, and after complete the evaluation form, you will get the CME credit for Thai people. So, Namphon, do you have any questions or comments here?
No, Dr. Tanya.
Her signal is nothing. Thank you so much, Aaron, for joining us, and thank you, everyone, for coming in, shining in, talking, taking cases. Thank you. See you next time.
Thank
Bye-bye.
you.